So thank you very much to the organizer to have invited me to speak about not the French, but the French-Italian trial, which is called the PHRC Étoile. It's a randomized trial comparing carbon ion therapy versus photons or even proton therapy for radio-resistant tumors. In the author of this communication, you have in blue the French collaborator and in green the Italian collaborator. So the idea of this trial was to try to study carbon ion therapy in a country where we have no center for carbon ion therapy. So we are recruiting patients in France, and after randomization in the experimental arm with carbon ion radiotherapy, they are sent to Pavia for the treatment in CNAO. So I will show you the organization, the principle, and the way this trial has been set up. That's the first points. And at the second part of my presentation, I will give information about the advanced and the present state of the status is the four last point of the presentation. So the objective and the history of this trial took its source when HIT has opened in 2009. And at that time, a rising demand of patients from France appeared asking for reimbursement by the French health insurance of carbon therapy made and proceeded in Germany. So this urged the Ministry of Health of France and the Health Insurance of France to ask for scientific assessment of carbon therapy. And this mission has been given to what we used to call at that time the Étoile project group, led in Lyon. And the Minister of Health asked us in October 2010 to make a proposal for this scientific assessment. First, we released an application for funding in the frame of what we call in France the hospital program for clinical research, which is a public funded program, mainly funding academic studies besides the industrial studies we know all of us for drugs. It has been deposited in 2011. And we have been selected for funding. This study has a pragmatic goal. It was to compare two care paths, which is not exactly the same principle of all the trials you have presented before. One of these care path, workflow, if you like, is with the best possible available radiotherapy in France versus one with the use of carbon therapy. And that was according to the point of view of our health insurance. The question was, do we have to support this care and ultimately to provide it or not in France? So we propose a phase 2 trial, and we have been asked to modify it for phase 3 trials. So it has been set as a multicentric. Multicentricity is in France, transnational, because the patients are going in Italy, in CNAO, and with the randomization between the two arms. The reference arm could be photons in most of the case, but also protons according to a specific way to choose. I will show you later on. So the main objective was to demonstrate a progression-free survival, not a local relapse-free survival, but a progression-free survival at 5 years. And the hypothesis was the 20% improvement. We introduced in that study different indications. Both are radioresistant tumors, but it's not reserved to one solely indication. And we accept adenoid cystic carcinoma, chordoma, and sarcoma. That's not a surprise for you. The secondary objective were, of course, survival objective, overall specific, and local control rate, but also, and that's very important, early and late toxicity and quality of life. This study is associated with two associated studies, which are not optional, but mandatory. a medico-economic one to be able at last to define the cost of this treatment and the cost effectiveness and the cost to utility based on quality, and a biological study looking for biological markers related to radioresistance and outcome of the tumors, mainly for sarcoma at first. The inclusion criteria are very simple. Adult patients with no severe comorbidity, giving them a life expectancy of at least 10 years. The tumor should be visible to have a GTV, so no resectable or non-operable or definitively HER2 resections, and presumably radioresistant cancer according to a limited list, but more than one indication, and with more details. I said adenoid cystic carcinoma of head and neck, laryngeal and tracheal were excluded due to movement. Soft tissue sarcoma included rhabdomyosarcoma, only pleomorphic type, and angiosarcoma. Retroperitoneal sarcoma, unless technical limitation, which is often the size, often the case, we didn't include one as yet, because of the size, because of the movement. Osteosarcoma of any location and grade, except a wing sarcoma. Chondrosarcoma from spine and pelvic, except skull base. That was a demand of our colleagues from proton centers. And of grade of World Health Organization equal or above 2, and chordoma of the spine and the pelvic, skull base excluded. Again, that was asked by the proton therapy centers. No skin involvement, that's a requirement from CNAO. Performance status, correct. Patient physically and psychologically able to follow treatment far from home, that was a restriction by say. And for women, no expectancy of pregnancy, social security affiliation, of course, and signed informed consent. And we had some special requirement to fulfill the randomization criteria, which were threefold. First, a radiotherapy proposal by a local specialized tumor board. So the decision of radiotherapy should come from another department than the group organizing the study. Second, the validation of this proposal by the Carbon Ion Center medical team. It is the CNAO team, so they have to check all the medical case at first, and if they say it could be a carbon ion indication, and third point, if they are able to treat it in the 2 coming months, this double yes was giving way to the randomization. Exclusion criteria were R0 or R1 surgery, previous irradiation in the same anatomic site, so we had not re-irradiation, metastasis of any kind, any contraindication to carry out radiotherapy, of course, but we also exclude planet surgery or chemotherapy after radiotherapy. That doesn't mean that patient couldn't have that in case of relapse, but it should not be a way to place the carbon ion therapy as a neoadjuvant treatment, if you like. Any metallic device, of course, in the volume or near to the target, modifying the image. Any previous cancer was possible if they have more than 5 years of remission, and of course, condition making the follow-up impossible would be also an exclusion criteria. So the organization of the trial was this one. So you see, it's a little bit more complicated than usual because we have this need to send the medical records to CNAO and to exchange with them, have the answer, then to make the randomization. So we use for that the HERO, so that's Heidelberg Institute for Radiation Oncology, the research database of Heidelberg, which has been partially funded by the ULIS program, which was a European program funding research in carbon ion therapy and hadron therapy some years ago. So this platform allowed us to deposit information in different files and to make them available to CNAO. Then they answer us. Then later on, we could deposit the treatment planning, and later on, during the follow-up, we could deposit the image so that we can, from any site, have information. So the randomization were 1-to-1, carbon ion on one hand, and other treatments, photons or protons in France on the other hand. The number of patients and the calculation of the number of patients was the following: to demonstrate the progression-free survival of 50% in the control arm versus 70% in the experimental one, which give an hazard ratio, of 0.5. We had to recruit during a 2-year period. That was my question a while ago. Do you have a limited period for recruitment? It was not period to wait for the recruitment. 2 years, a minimum follow-up of 5 years, a bilateral test with alpha risk of 5% and the power of 90%. We calculated we have to recruit 108 patients per group. We extend this number to 250 as a total. And we were waiting for 92 events at the end of the follow-up. The patient should this way be in the trial during 5 to 7 years. And the inclusion started in December 2017. So this study has been funded through several ways. The sponsor was the University Hospital of Lyon, which calls HCL. The financial support has been obtained from the French government through the PHRC program in 2011, up to 500 euro for the scientific part, monitoring, database, following of the study, insurances, opening of the centers, and so on. The French health insurance committed to afford all the treatment in both arms, and for the whole number of patients which was foreseen, it was something about 7 million euros. And we had a complementary support for the health minister later on for the housing of the patient in Italy. The data management was organized in different points. So we had the exchange platform of Heidelberg. The data management was done by the medical school in Lyon, the Laennec University faculty, and the statistics are made in the Centre Léon-Vérard in Lyon. And the carbon therapy, of course, was made in CNAO in Italy. We gave some treatment recommendation, but with a specific point. The treatment could change during the time of the study without difficulties, since we are testing, as I told you, 2 different paths of care. And we are not testing a specific form of treatment comparing to another specific form of treatment, neither an indication, neither a specific dose. So that's a recommendation. And this recommendation could change during the trial. I think they have changed a little bit for carbon ion from the beginning of our discussion and the opening of the trial. If investigator could do better, they are welcome to do better. If they are not able to reach this dose, in fact, in photons, they could ask for a proton therapy. And for organ at risk, the protection recommendation was the current recommendations. So you see, on the standard arm, the treatment are long, 30 to 35 fraction, and in the experimental arms, the treatment is far shorter, with 16 fraction in 4 weeks, which is in a way a way to console the patient going abroad. So if it's necessary to have a better protection of organ at risk for the for the standard arm, it was possible to ask for a comparison, a dosimetric comparison, and an NTCP calculation. And if the NTCP calculation show that we have a difference in favor of protons between 5 to 10%, according to the type of risk, we could switch for proton therapy. Below this difference, we keep on with classical photon therapy. So we have activated this organization twice for from the beginning of the treatment of the trial. So what is the advanced state of the study? So we have opened a large number of centers in France, up to 20, as you see. All the big towns of France are included. Almost, frankly speaking, almost all the anti-cancer centers are included, except Institut Curie, if you are looking carefully to this picture. And all these centers were able to send their patient to Pavia in Italy. The recruitment started, as I told you, in December 2017. It took us 6 years to install the study. I could come back on that later on. And during the 5 first years, because we are more at a little bit more of 5 years now, instead of recruiting all the patients, it was foreseen in 2 years, remember, we recruited only 10% of the foreseen patients. So the patients included are, you will see, and it's a very important point, we included 59 patients. 59 patients is more than 10% of 250. But among these recruited patients, only half of them have been validated by CNAO to be randomized. So we randomized only 29 patients. And so it is a difference you see on this chart. The orange bar is the included patient, and the green bar is a randomized patient. And then it is separated in 2 arms. And so you can imagine that we have treated in carbon ion only, let's say, 15 or 16 patients in 5 years. And you see also on this chart that there's inactive centers which have sent no patient, and these inactive centers are huge towns or institutions. So we have an activity only from rather small centers, which is really problematic for us. So if you like, you could see on this chart that more or less we were recruiting. So that's the inclusion rate. That's not the randomized rate. That's the total number of included patients. So you see, we included more or less 1 patient per month along the years. This statistic is the date of point is the middle of 2020. So now we are at 59. So frankly speaking, the speed was the same along the years with only 1 patient a month, sorry. The structure of the patient population, it is mostly adenoid cystic carcinoma from head and neck, 9 above the whole set of patients, and the other part is sarcomas, as you see, and chordoma also, mostly, of course, mandatory by the inclusion criteria from pelvic location. So we were surprised by this ratio of 50% patient rejected. That was a surprise. We were, of course, looking for a sort of ramp up or educational ramp up in the study, but not such a rejections rate, which is constant and stable along the 5 years of the trial. The excluded patient from randomization came mainly from refined criteria of indication given by CNAO, which were difficult to include in standard words in the inclusion criteria. So 18 of the patients rejected upon 25 are from this characteristic. I will detail a little bit more later. And presently, we have 19 patients on follow-up and 10 which had some event, which are progression or patient having disease. What are the reasons of the rejection of the patient? These are good reasons, of course, but which are a little bit difficult to foreseen by the investigators. As you see in such a trial with so slow speed, you have seen that an investigator, for instance, you can look on this chart, is including for some years no patient. So it is absolutely impossible to gain in proficiency with such a slow recruitment, rare tumors. And of course, specialized teams are far more refined criteria for recruiting patients. So tumor volume was sometimes a problem because the CRT field is about 25 centimeters. Some image artifacts, but not from metallic compound. It could be some modification of bone for cementoplasty, things like that. The need of spacer sometimes, which was impossible to place. Some positive nodes case. The high risk of necrosis of some part of the volume to treat, for instance, in case of reconstruction flap, high risk of osteoradionecrosis of skull base in some adenoid cystic carcinoma that could threaten the internal carotids, difficult tumor location needing specific incidence angles would need a gantry, so that was some limitation we have seen in the recent years, and sometimes they deem the situation as mostly palliative. So if we want to introduce the discussion of the specific difficulties of such type of trial, first we need 6 years to install this transnational trial because of the transnational formalities. We had to validate the trial in the same term, but in French on one side and in English, translated in Italian on the other side for ethical clearance, for the documentation released for the patient, which is not exactly demanding the same details in both countries, and then to make possible in France to validate a treatment which is going to be done abroad. So that was puzzling for our health authorities, and we need the help of the Ministry of Health to go beyond these difficulties. So it took some time. The eligible cases are rare, thus any inclusion is, we may say, a restarting story, a ever restarting story for investigator. And it's difficult to gain a level of routine, which will help and, of course, make considering complex things less complex. Often the referral of the patient was late after some consideration of diagnosis, alternative treatment, and so on. So we had advanced disease. That was sometimes a case of rejection. The difficulty for doctors, but I think it's the same everywhere in the world, to refer patient to another center. That's a loss of doctor benefits. The patient commitment to go abroad, the patient have refused sometimes to go abroad because they didn't feel them able to do that. Ever so, the welcome in CNAO is excellent, and the patient coming back were always very enthusiastic and thank very much the CNAO team, but people could expect that it could be difficult at first. Some technical problem of complexity. This trial is not easy to run because we have to rush when the randomization has been done to obtain the clearance from the health authorities to send the patient. We have a specific track for that. It goes rather fast, but it is some work, and we should be there at the good time. We use the S2 form to demand that. We have to organize the refunding of the travel. Sometimes we had computer compatibilities, difficulties with the HERO platform, and so on. The lack of experimental treatment funding, that's a problem also. This type of study is quite expensive, and we have no industrial funding, as you know, so we rely on public funding, and we are truly speaking in competition with drug trials and drug studies, and that will be a problem, and it is presently a problem of this trial. The lack of investigator attractive rewarding, we cannot in a public money trial of this way to give a lot of rewarding to the investigator, and they could have far more, 10 times more, at least in some drug studies. Probably a lack of interest of most of the radiation oncologists regarding hadron therapy. And maybe some of you are understanding what I mean with that, according to the situation in their country and the long time course of this kind of research, which is really difficult to understand for the present time, where some trials are going so fast and we have early release of new drug and so on. So a long-lasting trial and difficult to understand by sponsors. We have some specific difficulties in the PHRC étoile. The difficulty to recruit patients, you have seen many large centers remain totally inactive. This difficulty is, by the way, similar in the recruitment of proton therapy in France. So I make a real parallel between the two. The constant 50% rejection of recruitment patient with no learning improvement have been an unexpected difficulties for investigators. That was not foreseen this way. Several opportunities to extend the study have been void. We tried to make proposal of sibling studies in Luxembourg, in Italy, in Austria. It has not been able to be set up. We have no acceptance of our sponsor to enlarge even more the number of inclusion centers because it's some expense at each time. We propose to define a status of associated centers beside reference centers to alleviate the formalities and the paperwork for these centers, but that was not accepted. So finally, the recruitment rate being too slow to make possible to fulfill the requirement of the study, the sponsors, the University Hospital of Lyon, decided after several consultations, we are speaking about that since at least 1.5 years, with partners and investigators, to stop randomization end of June 2023. So that means that since 7 days, the randomization is closed for this study. However, the French health authorities are keeping on demanding real comparative studies to estimate the real benefit of carbon ion radiotherapy and of hadron therapy in general. That's the same for protons. And outside the randomization, the definition of an unbiased reference or control cohort is puzzling. The difficulty to a priori define a candidate patient for carbon ion radiotherapy for a non-specialized oncologist, radiation oncologist, in a country in which we have no centers is of great concern. As you see through our experience, we have 50% chance of error in deciding this allocation in a way.
Excuse me, we are already finished the time of the question. Maybe I can ask you to speed up and wrap up.
Yes, okay, I'm quite finished. So the perspective of continuation comparative studies are still open. We will continue to send patients abroad to HIT and CNAO at the expense of the French health insurance. And this is, truly speaking, ongoing since October 2010. At the beginning of the preparation of the study, the health insurance allowed us to do that. We have treated this way 45 patients. We have treated this way 53 patients, but some of them are irradiation. But you see on the right-hand chart, we have 32 cases that are the same patient that in the PHRC. They could be added to this patient, for instance. And we expected that a reasonable advertisement and a much simplified procedure will increase the number of patients we could send for carbon ion therapy. However, the definition and moreover the setup of a control group, which is a demand of authorities, is really an unsolved problem as yet. And we will have to discuss about that in the future. So we hope to develop an ETOILE 2 study in the coming month, and that will have to fill the gap between the present time and the opening of the French Carbon Ion Radiotherapy Center in Caen in 2027-28. You have heard about that. It's the ARCHADE project, for which the principle of prospective evaluation is not yet completely finalized, but we will certainly be in far more good position as in Heidelberg to randomize patients in-house with a mutualized means of clinical research for several studies, and that would certainly more easy at the point of view of the organization. So my conclusion is just a repeated information of what we have said. So I will just leave you discovered in the presentation that is free of any limitation, so you can keep it.
Thank you very much for sharing all the details of this complicated trial. I saw no questions in the shared document, and maybe we proceed with the next presentation, and at the end